and now I'm pleased to introduce Adam Bowler and your opening general session. Adam Bowler, your facilitator for this morning, is CEO and founder of Landmark Health. He comes to us with an extensive and unique history and relationship to home care and hospice. Prior to founding Landmark, Adam was the founder and CEO of A Labs, which is currently the largest provider of comprehensive laboratory management services to health systems including Sharp Healthcare in San Diego, Advocate Healthcare in Illinois, and Aurora Healthcare in Wisconsin. Before founding A Labs in 2011, Adam worked in the financial sector, responsible for healthcare investments and analytics at Accretive, Mead Finance, and Battery Ventures. Please join me in welcoming Adam and the panel to the stage.
Thanks. Thanks for having me, Meredith. It's a pleasure to be back here and to see so many familiar and friendly faces. As the panelists take the stage, and I'm guessing you know a lot of them, but I'll have them introduce themselves and then spend about a minute talking about the state of home care. But just a few ground rules before we start. One, the first ground rule is we haven't over-prepared here. It's not going to be a panel where we just ask questions and everybody's prepared and scripted. So my first ground rule is I'm going to go to you pretty quickly and ask for your questions. So the things that, the deep, dark things that you don't want to put out in the room, I'd ask you to put them out in the room, throw those elephants in the room out there, with one exception, which is, make sure that they're relevant to 80% of us at least. So, don't ask Mark Heaney what color his underwear are, or what, they're red, by the way. So that's rule one. The second rule is that I've been specifically told by Meredith that I have to interrupt people. I think that might have to do with Bill Bourne specifically. All the hospital-based home care people love that. But feel free to interrupt, and I will too. But the idea is to get kind of the room moving and to ask specific questions and to do that. So let me start, and I'm going to ask each one of our panelists to introduce themselves and then just spend a minute giving you kind of their view of the state of home care today. And they can also reflect a little bit on the past and what their predictions were and whether they came true from the past. So let me turn it over. Bill, there's a lot of Bills here, by the way. Bill, you're right on my side, so do you want to begin for us?
Great. Thank you very much. So I'm Bill Mills. There's at least 3 Bills on the panel today. I'm a physician who's Vice President and Chief Medical Officer for Care Management, Home Health, and Hospice for Kindred Healthcare. I came into the company about a year and a half ago after doing house calls. So the kind of old school practice where a physician has a black bag and knocks at the door and tries to do the very best he can for that patient in need. And over the last year and a half with Kindred, I've been responsible for many of the growth initiatives on the home health and hospice side, and really trying to connect a lot of the dots within a large company like Kindred to be much more kind of patient-centered and patient-focused. So I think where home care is today, it's, I think for the first time, truly become the preferred place of service. I think it's the preferred place of service by patients, by families, I think increasingly by acute care systems, and I think by payers. So I think that's a pretty good spot for us to be in. I think in the future we have to build off the momentum in home care, and I think, in my view, the future is all about integration. It's all about having home care as the preferred place of service, start to incorporate much more thoughtful care management, population management strategies, and to be able to be much more integrated with primary care providers, including house call physicians. So I look forward to the panel. Thank you.
So I'm not Bill. I am Erin Denholm, and I am Senior Vice President for Centura Health, which is the largest healthcare system in the state of Colorado and is now in western Kansas. It's an integrated delivery system with 15 hospitals, multiple home care and hospice agencies, 7 senior living communities, and a physician network of about 3,000. and 480 of those physician practices are owned. We decided, I had the great privilege 5 years ago to be on a panel with some of my colleagues thinking about actually talking about where are we going to be 5 years from now. We were asked to look at that in our comments this morning. And that was just when ACA had come out, and we had the early, medium, and late adopters in terms of thinking about, is ACA really going to have any stickiness? Is it really going to happen? Our organization 7 years ago decided to be early adopters of population health. We are really all in, especially in the last 2 years. 42% of Colorado's market has moved to some kind of management. Although there is no global cap, the readiness is very much there, and there's great interest. We, in our organization, have a Medicare ACO, Medicaid ACO, 5 commercial ACOs. April 1st, we're all in 2 bundled programs, one for joints and one for cardiac. So in terms of thinking that perhaps population health is really something that's coming to fruition, that prediction was pretty spot on. And I would say that in terms of where we find ourselves, I think that for our organization, we're moving much more into home care being a cost-based, very cost-effective, cost-based center as opposed to a revenue center. And we have absolutely seen and have data that shows total cost of care decreasing with post-acute home-based services that have not been defined by payers' eligibility criteria.
I'm bill number 2 at this point, but I deserve the respect of all the other bills because I'm the oldest bill here on the panel. I never thought I'd reach that stage in life where I'd be the oldest person at anything. But I had the privilege of being on the panel with Aaron some 5 years back. I'm vice president at the National Association for Home Care. I've been in home care areas, work since 1975. I've seen what's happened in this industry firsthand from a beneficiary's perspective on through every one of these companies in this room. And when Aaron and I were talking about where our predictions went from 5 years ago, we were pretty much on target with 1 or 2 exceptions. We expected and have seen, and will probably see for the rest of our lives, reimbursement threats from Medicare and other payment sources. But we've also predicted that we'd see some innovation developing that would really draw people's focus towards home care, whether it be the ACOs, but particularly bundling of services, which we are now seeing taking off nationwide, very likely to have a longer lifespan than ACOs. But the one thing I think that we offered as a panel 5 years ago is that we believed that opportunities would increase significantly for home care. And when you look around this room, you could see that those opportunities not only surfaced, but they paid off. I mean, this is the largest attendance I think they've ever had at a Home Care 100. So anybody who 5 years ago was thinking that was the end of the industry, it was going to completely fall apart with all those cuts, you're here at the Ritz-Carlton in Laguna Niguel, and so something must have worked right. But when you look across the country now and you see those opportunities, they're coming from Medicare, they're coming from the hospitals back to home care, they're coming in integrated care, the physicians are aligning themselves with home and community-based services. Every Medicaid program in the country is rebalancing in favor of home and community-based services, and managed care companies are looking towards home care as a prime solution in the management of people clinically, but also financially. So I don't know whether we had a great crystal ball back then or just got lucky, as the Patriots did last night. Someone from New England, myself, yeah, I'm from New England, so I can get away with it. But looking forward to the panel today.
Yeah. So, my name is Mark Heaney. I'm president and CEO at Addis Home Care. Addis is a personal care provider. We're in 22 states, and we serve 33,000 overwhelmingly dual eligible persons on a daily basis. And I did read the notes, the comments that Aaron and Bill provided to us 5 years ago, and I was in attendance for that. And I think you're right. I think you were right then. And I think it's important that we say that because we're going to talk about things, and we have been talking about things as a group over the last couple of days. And I think we're going to be right again. I think there's like really some smart people out here, right? Like most of us. And I heard Marcia laughing, and I mean, including you, Marcia. Yeah. So here's what I think. I think that I think we've been right. I think that we have an acute model of healthcare delivery in this country, and I think that we cannot afford it. I think that we all recognize the deficiencies. The deficiencies are so bad that in just the flat-out best piece of real estate that this world has ever known in the history of ever, 40 million Americans can't take advantage of the services that we provide generally. And I think we're going to solve that problem. And I think we're going to do it by moving dollars in the trillions from the acute side to the pre-acute side. And I think that that's what we're going to do. Here's the thing. It's an economic imperative. Whether we want to do it or not, it's a flat-out economic imperative. We happen to be on the side that will benefit from the economic imperative. And I'll leave with this. We serve overwhelmingly the 5% that use most of the health resource in this country are older. And here's the thing. In 2012, the average life expectancy was 78. If you're 65 today, you're going to live another 8 years. 8 years. So when is that going to stop, right? Is somebody, we're going to pass some rule that says, no, we're going to stop that? And of course not. And by the way, we're adding those years onto the dependent, the most frail, the elder. We're not taking and adding 8 or 9 years to your 30s. We're not doing that. We're saying no. So we can't do anything else but to serve this huge population but at home. And that's what we do.
Great. I'm Dee Miller, and I'm the National Director for Acute and Post-Acute Care Management at Catholic Health Initiative, CHI. We have 105 hospitals across the 18 states, and we really, really believe in population health and have been managing that for about 3 years now, and really looking at how do we maximize the expertise of people such as yourselves in helping us to achieve the triple aim? And so we recognize that home care is the way to go. Patients want to be cared for in their homes. And so what we do is look at, we have owned assets in home health as well, and we also look at all the post-acute venues and say, what is the right thing for the patient? We really want to make sure that we're keeping the patient in the center of what we're doing, because we know that they're going to become the driver. So we have 10 ACOs. We have 34 bundled payment programs. We have a couple of innovation grants in which we're looking at not only taking care of our defined populations, but taking care of our healthy communities. And so we recognize with the increasing lifespan, with the preferred partnerships that we all have common goals, and that is really to make sure that we are delivering care in a cost-effective manner with the best satisfaction and better health outcomes. So that's really where we come from, and one of the things that is important that some of the panel members have already mentioned is innovation. So we know that Medicare has the shared savings programs. We know that they have the bundled payments, but what's next? What's beyond that, and how do we manage that through the resources that we have? And how do we become active participants? And one of the things I don't think we've completely solved, and I think home care's niche would be, is to actually look at that before they have an escalation and crisis. So the chronic care management. How do we continue to support in-home care transitions? We all have our specialty niches, and so we need to make sure that we're actually partnering to actually enhance what we're doing for those patients. So thank you for having me on the panel. I look forward to it.
So I'm the third Bill. You can think of me as the one that's been born again. I had an opportunity to have a sabbatical, so I've had a rebirth in my personal life, which was great, as well as my spiritual life. I think today might mark the return of my professional life, so I'm excited to be here. I put my glasses on, and they're not rose-colored anymore. I can see the industry clearly, but I realized it wasn't a whole lot different than when I was here about a year ago, actually active in the industry. When I look back at the Balanced Budget Act of 1997 with President Clinton, there was an inflection point in our industry. We moved from a cost-reimbursed industry of high utilizers to one that became capitated, episodic, and allowed us to make a profit for the first time. I think 15 years later, approximately that time, looking at S-cycle dynamics, we are confronted with the ACA, Obamacare. That's created a much bigger inflection than the BBA of 97 could ever have created. And it's really rearranging the chairs on the deck and actually throwing a lot of chairs off. And we're actually in a situation now where we're playing musical chairs. So the question is, when the music stops, are you going to have a place to sit? And how are you going to position? As a result of the 97 and 2000, we were able to reinvent ourselves, and the industry reignited itself from within the industry. I'm here to tell you that's not going to happen here. What you're going to see is a whole nother breed of players, and I'm afraid those players aren't coming from inside the industry. And you just heard it over and over again. It's the ACOs, it's the bundles, it's the care-centrics, which are insidious, which will come upon you. It's the NaviHealth, it's the remedies, which I help sponsor and fund. And then you have the bigger boys who are Humana and the kindreds of the world that are going to change the dynamic of how we live. And I think right now, we as an industry can be innocent bystanders. While I see huge opportunities and a more fertile environment than I've ever seen, I see that in the home nursing benefit, which is different than home care. So I heard home care at least 100 times, maybe more in this opening session. And I want to tell you, home care is different than a Medicare home nursing benefit. You need to be careful, because if you're in the Medicare home nursing benefit and you try to put your crops in the same ground, you're going to have trouble. It's not as fertile as you think it is, and you have to figure out a way to change that. And I hope today in this session we can do that. In closing, I will tell you, we think that home care is cost-effective. It's a cost-effective environment. But the Medicare home nursing benefit is not very cost-effective in the way we deliver it. And we're not achieving the outcomes. And the government and the people who sponsor and support the government aren't getting their value. I hope we can dive more into that today.
Okay, so I know you want to get to the audience, but
Sure.
We're going to disagree in the next hour.
Good.
So
Not a good session if you
yeah, I
don't.
just thought I'd throw that in. All right.
So one other quick note, which is if the Home Care 100 people that have the mics, just raise their hand if people could look. So if you have a question, I will look for you also, but just kind of get one of them and they'll get me as we go on if you'd like to ask a question. Let me start off. So one of the things that we spoke just a lot about, and it was super thematic in all of the comments, was kind of a shift to value-based care. And as I look at the panel here, so you look at the participants, absent Bill, the second Bill, you see either people from large independent, so that would be Bill where he was and Mark, or you see people from integrated systems. These are not, there's no kind of single home care agency representation out here. And so, I was thinking about the different comments. I mean, you talked about the number of ACOs, you talked about what you're doing in terms of bundled payments. So let me ask a very specific question, because it struck me as I'm sitting here and then I look in the audience. Is this kind of the end of the independent home care agency?
Well, I'll jump in. I have a very specific example, and some might have heard me talk about this. We have very competent and powerful IPA of 235 primary care physicians in Denver who have a significant Medicare Advantage, and as well got the only pioneer ACO Medicare program. So it amounts to about 70,000 seniors. When they got all their claims data, they were disbelieving, actually, to find that there were 111 different home care agencies who were providing services for their population. And they blew the whistle on that and said, we're going to have 5. They put out an RFP. People responded. Our organization is one that got chosen to be one of 5. And of course, those of you who are in the audience thinking, wait, what about choice? You can absolutely comply to the letter of the law And a primary care physician who has a keen relationship and understanding both of their patients and the business model are going to tell their patients, you have a choice. And the organizations that I work with really well are as follows. There aren't very many patients that will go against that. So with that in mind, totally compliant to the letter of the law, there are now 5 primary home care agencies, very small amount of leakage for about 70,000 seniors. And the mom and pops are hurting. So I would say, I think that the cottage industry is really being minimized.
Go ahead, Mark.
So
yeah.
I think that this is Home Care 100. And I mean this very genuinely. I think there's at least 100 survivors in here, right? Because the answer is, for me, it is the start. It's the very, very, very beginning of the end of the smaller freestanding. And by the way, if you're a rural, smaller freestanding, you're going to be fine in your lifetime. There are no young people in here young enough to know when that's going to go away. But I believe this. I believe that if you're really good at a specialty in a market, there's a place for you for the foreseeable future. You can retire on it, but you got to be really good at it. And if you are an independent in a market and you expand and own that market, you might be in Denver and not in Cleveland. You're going to be fine in Denver. And why do you care? You don't want to be in Cleveland. I don't mean not be in Cleveland. I mean Meredith. I mean that you. I mean, okay. So no, if you can dominate a market, that's where the healthcare has to be delivered. I think you're going to be fine.
So you just said kind of 100 survivors, and I don't know how many people there are in the room or how many are at Home Care 100, but let's say there's 300. So basically, perhaps it's implying that 2/3 of the people here won't be here anymore.
No. I mean, very clear. I'm going to be really clear. There are, when you say Home Care 100, figuratively speaking, what we're talking about, people are here engaged in asking about what's going to happen tomorrow. This isn't, and I don't mean this, I'm a member of NAC and a lover of NAC and a former board member of NAC, but when you go to a NAC meeting, you're talking to an awful lot of people. Yeah, they're not going to be here. Now, they'll be in home care because we're going to have to provide so much more home care than we currently provide as we try to take care of this huge, older, sicker population. We're going to do it at home, but you won't be as a freestanding, independent agency. We don't need 12,000 CEOs in this country.
Right.
And I think actually to add on to that, to Aaron's comments and Adam's comments, the integrated system. You know, we as an organization go through, do we build, do we buy, do we partner? Who's the experts here? And how do you make yourself even more valuable and build your expertise to continue to deliver that? And that's what we look at as a system. So we actually do, much like Aaron's experience, we actually in our key markets are making preferred networks, preferred partnerships, and participants that can gain from the value-based care that we're delivering. But also on the other side of that is that we're saying patients always have a choice. So we know that you are going to experience some leakage outside of your preferred network, but if you're doing it well and messaging it well and really managing your population, it's very little. So I do think that will be effective. So to Mark's comments as well, if you rise to the top and are really on top of your market, then you will be one of those people, whether it's an independent agency or a larger agency. And our philosophy is we have a home care company, but we also know that our home care company isn't in all markets, and so we have an additive. So we don't believe in just putting your eggs in all one basket. So,
yeah, Adam, if I could just add
Please.
just a little bit here, that from what we've seen over 3 decades is that the answer to the question is really more market specific. It's a lot different in Colorado than it is in Oregon, in Rhode Island, New York State. Everywhere you see something different. Texas has not embraced managed care, but everybody in Rhode Island is in managed care. And we're also market specific in terms of the type of home care or hospice that you provide. There's a huge difference, I think, in the future for Medicare home health agencies than there is for Medicaid providers of services. And certainly a lot different also for hospices. But then the private pay home care is a fourth field that we rarely mention, but has just unchecked growth when it comes to some of the integrated services and the government regulation and government payment kinds of things. So, I mean, I certainly agree with Dee that I think everybody's going to have the opportunity to be there for the next generation, so long as they properly examine that marketplace, properly examine the part that they want to have in that marketplace.
So I want to further this one more question around this, and then we can move on more to value-based. But what's your advice? If I'm sitting out there and I am an independent agency, and let's say I'm not, I agree on the rural side, choice isn't probably going to be enough, because obviously, yeah, there's choice, but if I go to a health system and they have a home care agency and there's a preferred recommendation, we all know kind of what happens there with some minimal exception, but that's not going to keep an agency afloat. So what do I do?
I would mention that I think outcomes, communication, and satisfaction almost always trump just about everything else. And I think specifically thinking about senior living communities, assisted livings, I think many of the places where our population in need lives, I still think there's a great and unique opportunity for specific program-based home health and hospice agencies to really deliver an integrated model within these communities. I still think that even though we've seen consolidation, of course, in assisted livings, I think there's a real opportunity there.
And I think that, we've said home care in general, but hospice and palliative care, we know that people want to be managed at the end of their lives in a way with dignity and a way that they can stay and maintain quality of life. And that's a big piece of the puzzle too. So often we'll actually kind of combine those issues, but it's also necessary to separate them out, because there is a real specialty when you're looking at an older population or end-of-life issues, to make sure that we actually look at our company, we actually look at palliative care and home care separately while they can be together. And to your point about getting out into the assisted living communities, the senior communities, and looking at wellness and prevention, as well as chronic care management, transitions of care.
Yeah. So I think also, just very fundamentally, I also believe it's not too late for anybody in the room, any of us in the room, and more of us outside the room. It's just not too late. This change is going to occur, but it's going to occur in a way that we can keep up, even if we're a little behind to start. I think, but we are not going to spend more. So what we need to do is become more efficient in our basic operations. So take our administrivia out or flatten that out. Begin to think about how you demonstrate effectiveness, be effective and demonstrate effectiveness. But we're going through change in our organization. And one of the things that I've realized, and I have to, I'm a part of the problem, and it is that we have to I'm excited about it, but we have to accept that we have to change and surround ourselves with people, leaders, who adopt the change and want to change, and then permeate that through the organization.
So thanks, Mark. I have one more question, and then I want to actually ask if there's some audience questions on the topic. So one more question on the independent home care side, which is we're kind of reflecting the future of what's going to happen. Should I get ahead of it, and should I sell my home care agency to one of you, since you're large, and are you buying?
What's the multiple?
So I'm curious, the panel's there. Are you buying?
I beg your pardon?
Should I sell my agency to you?
If you're a good agency and your multiple's low enough. We are buying. Yeah, no, we're looking at Texas. So the answer is yes. Because what's happening is there are people outside this room who understand what's going on, and if you're at some point in the development of your small business in some state, and you look forward and say, am I going to do the things that we're talking about, what are necessary to survive, as we're talking about in this room, or am I kind of done? And by the way, do I have a really great organization doing good things? Yeah, we'll absolutely buy that. We want to get broader and denser where we are, and we want to be where managed care is, and there are opportunities to do that. Absolutely.
How about on the hospital-based side? Do you guys buy home care agencies?
We actually are not looking to buy home care agencies. However, again, as a hospital system, however, we do have a home care side of the business, and their strategic plan is very much as you said. Are you performing well? Are you bringing value? Are you able to partner? So as the health system itself, no, we're not looking to actually buy home care. We know that we're not experts in it. We know there are plenty of experts out here.
And from our perspective, we're looking not to buy. I would say, what are you buying? You know, there's no guarantee that you're going to have the same providers stay when you purchase. There's a great risk in terms of buying a home care agency. That said, we are extremely interested in partnering, and I think, to Bill's point, outcomes and satisfaction are key in terms of that, and especially because of our basic philosophy of having it be cost effective. We're not looking for a lot of revenue. We're looking for partners that can help us with the population way upstream, affordably, so outcomes and satisfaction would be very important.
We have a question. Let me come over.
Thanks. Louise Weddock, Access Nursing in New York, New Jersey, and Maryland. You know, I just want to talk about the aid. I think in everything that's going on in the industry and the consolidation, the mergers, acquisitions, and everything, I see a lot of these large corporations in trouble. I mean, they're in turmoil. They don't know what to sell. They don't know what to buy. And the politics are so intense on the inside that it really has left the marketplace kind of in irons, if you will. And so, you know, I feel like that gives a huge opportunity for a strong independent provider to just focus on the patient while you guys are trying to focus on yourselves. The other side is I feel like, and this isn't hostile, but I also feel like you've drank
we're not taking it that way.
Oh, okay. I also feel like, you know, back to the aid, I think you've drank the Kool-Aid. And so, you know, here we are listening to you guys. Sure, we're buying. Of course we're buying. Of course we're doing. You know, and you sit there, I'm a small independent provider going, holy cow, the sky's falling, even though the sun is shining. I better get out of here. But I don't know. I think maybe sometimes when everybody else is selling is the time that you know, stay in and watch it all fall apart. I've seen this. How many times have we seen the industry in healthcare contract, expand, fragment, contract, expand, fragment? It's so cyclical and predictable. So I agree with the effectiveness, the outcomes, the patient satisfaction, the niche production. I think, you know, a good player just stays focused on a really good game and forgets what the crowd is cheering about. I just focus on the patient. The other side is the aide himself. You can comment at the end. Just let me get through the aides.
I'm not buying or selling any home care companies.
Good, good. And then the other part is about the aid, because at the end of the day, doesn't it just fall down on the aid? So being powerful and influential and large players in the marketplace, wouldn't you do better flexing your muscle in Congress so that we can change the rules of the aid? My sister, who has absolutely no talent, is allowed to transfer, bandage, medicate, and bathe my mother. However, the aide that I have trained and has years of experience really is you know, limited in many of those respects. So if you're going to change the game, why not change the role rather than the structure of the marketplace?
So the history and the data supports exactly what you said in the first part of that, which is that there has been multiple generations of it's going to consolidate the entire industry mantra out there that didn't materialize. And the growth in the number of home care companies and the number of hospices out there, and then the private pay side of it, is in the small independents. And the large companies are acquiring each other rather than acquiring the small independents. I mean, there are more home health agencies today in Texas than there was prior to BBA 1997. Last year, over 300 new home health agencies came into existence, organically grown, that were not part of any of the large companies that are out there. The market does not seem to behave as everyone predicts the market's going to behave. And I think because one reason, there's a lot of entrepreneurship in home care itself, a lot of people who want to run their own business, and it's a relationship business as well. And so you do see these opportunities continuing to come in all of the sectors that are there. And then I was talking to Bill Bourne beforehand. I said, Bill, when did a Medicis really become a Medicis? I mean, his organization, his company started in 1982, but it didn't become a large company until after BBA 97. So he went from nothing to something huge as a company overnight. And in 5 years' time, the largest companies may not be the largest companies today, and they may have been built by small independents as well. So I have long thought that this is an unpredictable marketplace that home care is.
So I want to make a comment. I have been conspicuously quiet for the first session of questions. So I hadn't made any of those comments. So everything you said couldn't be reflected to me. But the bottom line is that, I get awful confused when I look at Humana and I see them having more value for an ancillary service than for a skilled service. And what they're saying is just get somebody to show up and put their hands on the patient, and we actually get better outcomes. And it's all about ADLs. That's what keeps patients out of a hospital, even more than skilled. And I think we waste a lot of our costs and our care in providing skilled services that might be just totally unnecessary, or providing skilled services that are just totally ineffective, or providing skilled services because it fits within a regulation, and we provide teaching and education support by sending a nurse and paying them not only for time and travel, but for the visitation, when we can as easily, if not more effectively, do it over a phone. We have to find a different way to come up with a way to touch a patient, and it's not in personal physical visits, but it's touch points and it's oversight and it's care management and it's coordination. It's having a good, sound clinical foundation. How effective is your care team conferences? How effective is your care management? You all talked about 5 agencies getting accepted in that network. I got it. I think it's the right thing. But once those 5 agencies get there, and maybe not y'all, Aaron, but I can tell you, many of those agencies got in that ACO and went, oh, wake up. Because these physicians, the very first thing they're going to start doing is looking at utilization, and they're going to start looking at outcomes. And I'm going to tell you, if we do it the way we've been doing it, when a real scrutinizing eye looks at it, it's going to be unacceptable to those physicians who are at risk. And that's going to be one of your biggest threats that's out there, these physicians who are going to take over it. Right now in the bundles and the ACOs, there are demonstrations that are waiving the homebound status. And a physician can send a nurse right out of his office to replicate and supplement and substitute for a Medicare home nursing visit. That's the things we have to be careful of.
I have to comment. So I appreciate your passion. I do. I mean, it's like evident. My comments are about this. It's just physics. I mean, you pick up Hawking's if you want. Okay. It's just things happen, and they're just going to happen. Gravity, it's like happens. So I'm just saying that in my view, we're going to have fewer home care agencies going forward. And I went through why, and I won't go through why again. We're just going to have fewer of them. However, we're going to provide a lot more home care. You said some things, and I have to say this. Look, we don't know each other at any level, but I've been, these people, and have been, that I'm sitting with, have been, I've been on boards with them, I've been, and there is a passion for what we do, which is fundamental to greatness. And this guy invited me to his strategic planning conference about 3 years ago. I had no clue why. He's just he does stuff like this. He just say, and he invites me to his strategic planning conference in Atlanta, and I go. And I just sat there. I didn't know anybody else other than a few people. And I came away, and I told actually Martha, I've told Bill this, and I mean it quite genuinely. It's a big-ass organization that this guy ran. And I sat there for 2.5 days, one, stunned at the quality of people that were there. All of the talk was about the patient experience and how to improve health and wellness. It was for me as a professional, I want to emulate it. So I've been in meetings with this guy and this woman, and there's a passion about the patient and a passion about the tool, the direct care worker that is, and I know a lot of people out there, and I think some of the things you said, we missed something. Okay.
All right, guys, we have, just for time's sake, we're going to move over to a question over here. Julie?
Oh, no, it was...
Oh, sorry, I thought it was you. Okay, you've got a mic.
Question for Bill and Mark. Very interested in your perspectives as leaders of large publicly traded companies as to cash flow management, strategic thoughts from that level as far as what you're getting feedback from on a national basis, a shareholder basis, an investor base. Can you make some comments about where you see our industry are in terms of those kind of arenas?
Why don't you go first? Thanks. I think you're talking to this bill, right?
Not this one.
Go ahead.
You're going to make me go first.
Yeah, not me, you ask you.
Thank you. Well, so there's a few things in there. I'll pick a couple. And investors, including private equity, but funds and shareholders, 4 years ago when we would say we were in home care, it's like some of them thought was like, building additions onto homes and stuff. It would. Everybody gets it now, and there is a strong interest in the space. People accept that we're going to deliver health service at home first is a mega trend, irreversible. There are bumps along the way. There's payers and states and things where there are issues, but overall, the economic imperative is that you have to have really quality home-based care in order to avoid somebody getting in an ambulance, which throws their costs off exponentially. So it's, look, home care is the fastest growing segment of the largest and fastest growing segment of the largest economy in the world, and Wall Street knows that.
Now, I think being a public company, the challenge is how you invest into the future. And you're always kind of living for the next quarter. And the public companies really live in a glass house. Glass roof, glass sides, glass bottom. So we have to be real careful about rocks. And believe it or not, we live in a total different set of standards because of all the compliance and the things that we have to go through because of trouble we can get into. We play by a different set of rules. So the people actually in this audience, not necessarily the mom and pops, but the people in this audience are best positioned to take advantage of the future trends, of the mega trends. Absolutely. You're more nimble, you're quick, you can put in better and quicker clinical solutions, and you can invest all your money. Had I had it my way with Amedisys, I would have invested all of my profits, and I practically did, for the last couple of years into the new system. We had applied for 60 and received 60 agencies in full bundles. And I applied for another 180. I had 220 agencies that were going full bundle, full risk. Why would you do that? Why would you take an agency that averaged $2,500 in a 60-day episode and sacrifice it all for the future? Well, because the bundles paid 5 times that. And all I had to do was reduce my recidivism. I had to reduce hospitalization by 50%. Imagine the value I would have created. Imagine how far up the food line I would have moved the food chain. Basically, I would have been in the insurance business without having to have open enrollment. I think there are opportunities for the people in this audience and this size that are much more phenomenal than the public companies have right now. I think all the public companies are strapped, and there's not a whole lot they can do to continue to provide that perpetual value. There's not enough morsels out there to feed that beast. You guys have a perfect opportunity to redefine yourself, reinvent yourself, move up the food chain. Don't be a victim from the people who are going to layer in between you and the payers. That's the threat. The companies I mentioned earlier are going to layer themselves between you and the payers. You don't want that to happen. You should be king of the hill. You should be king of your market. You should be taking risks. It's not that hard, because let me tell you the bottom line, is you'll be managing an unmanaged population The patients you get in Medicare fee-for-service are unmanaged. It's not like getting Humana's patients that's already been crammed down and utilized to death. You got patients who have never been managed. It's easy picking.
So Bill, I want to ask you a question on this one because I think it's a very good point you're making. So let me expand on it actually, which is everybody in their introduction talked about value-based home care. You hear a lot about ACOs. You hear a lot about bundled payments. So I'm sitting in the audience, and there's a lot of talk about it. So what can we do practically? So I agree with you. I think it is a great opportunity. What can they practically do right now?
They can apply for a bundle and get that accepted. I don't know what the time frame is. I've been out for a year, but the government has come back and said, hey, listen, you don't even have to take all risks. We'll give you a cap and we'll give you a floor. But if you're not in a bundled program, shame on you. You can be very specific. You can pick the diagnosis. It can be CHF. I like the specialization. I can tell you, I said it 100,000 times in Emeritus. If we got rid of all the multifunctional things we were doing and we focused just on providing the best home care in the nation, we would have a very viable company. And I think we need to specialize. I think we need to look at the diagnosis we can be really good at, and we need to be known as that company in that market. And then the big systems will flock to us. Big opportunity out there.
I'm going to hop in here because I think that when you go from volume to value, you philosophically as well as strategically have to change your mindset to well care from sick care. To really look at the legacy of what we've done, it's always been according to sick care. We intervene when somebody has a moment, which is a high-cost moment. The part about value-based system that is really important is that you have the data analytics for a defined population that allows the stratification of low, medium, and high-risk patients that then you can intervene proactively before anyone gets sick. So in terms of identifying home-based services for a high-risk population that has had high ER, high inpatient stays, and intervening, setting up telehealth, doing safety evaluations that are not defined by payers. We're not getting paid for those services, yet we are doing them. We have certainly the benefit of having a system that is at upside risk to be able to benefit for the costs that we are incurring to intervene before anybody gets sick. And we are actually showing the data, as I said before, that shows that total cost of care is going down because of what we are doing proactively. And that is values-based. And it is pennies on the dollar. It doesn't mean a 60-day admission. It doesn't mean a lot of nursing care. It has a lot of different complexities to it, and it's fun because we really get to keep our eye on the prize, which is keeping people well. A totally different perspective than what we've had.
And Aaron, if I wasn't in a system, what kind of message am I hearing in the audience? How do I do that? And I think what happens when you get that sick patient, you have to create value there. For instance, how many of you take a look every day at every care team conference at your readmissions and you have a root cause analysis discussion in reference to why that patient went back to the hospital? And I can tell you, if you do that, you're going to find that more than 80% of the times it's because you dropped the ball. And if you can start identifying that and producing those reports, that's the value outside of being in a system. Because only 20% of the population is in a system being managed that way. So the other 80% is out there for you guys. And that's how you would tie those two together.
Okay, we have a question over here.
I would just add, if I could just quickly, so I think the one ingredient, I agree with everything that the panelists put forth. I think partnering with a longitudinal care provider is really key. So, you know, kind of that transformation between the episodic nature and the longitudinal is really where you're going to get to that value. So, you know, there are more and more emerging organizations that do have an interest in physician house calls, advanced practice nurses, physicians assistants who are doing this work. So I would suggest considering partnering with some of those entities.
Thanks. This is, as one who sat in the audience 5 years ago and heard your presentation, even though I'm not a beaver, I can tell you, you pretty much checked off everything on the list. Having said that, we also know that we're moving into a period of more self-management by the patient and caregiver in the home, and that seems to be redefining the paradigm of care delivery, because if in the regulator's mind, unless you touch them or do something to them, you haven't really delivered a service that you can somehow bill on. And the other thing is that in terms of absorbing the pre-acute, the wellness factor, it seems that in order to innovate, we really need to start looking at that paraprofessional workforce. And as the only professionally mobile workforce in the industry, I think short of the military, I'm wondering if you can share with us some of the ways that those of us that are not in the direct care market can support our providers in order to get innovation out on the table, begin to stimulate the regulators to rethink the roles of paraprofessionals and kind of break out of those models so that we can drive that down. And to add to Bill's piece, that 80% root cause is communication failure. So thanks for bringing that out too, Bill.
I think it's perfect for Mark.
You're going to wade into that one?
Well, actually, I turned to Bill and I said, that's a great question, but I mean, I really do. I think it's like super, but maybe I had the wrong interpretation. So you said other providers who don't provide direct care. Okay, so I'll just throw it out there. So I think everybody in the room believes that we're going to be serving more and more sick people, sicker and sicker and sicker people, more and more highly acute people at home. And we're going to do that that's it. It's a mega trend, and we're going to do that. And a real quick thing, you know, and Bill's gonna, so Bill, you know, you talked about not driving outcomes and stuff. What do we know? Look, we have more and more older people than we ever did before. We're providing more home care than we ever did before, and nursing home placement in this country is essentially flat, and we're living longer. So it actually does drive an outcome. So I think what I'm saying is that, so thousands and thousands, millions of sick people are going to be out in the communities. We have to know who they are. And somebody was mentioning like Navi Health and some of these great companies. So where are these people? And then how do we, so going to their home, we have to have the logistics to get to their home, and there's a whole set of things that go with the logistics. And then once we're there at the lowest possible cost, and I agree with you, the community-based paraprofessional is a good like private or corporal in the Army, lots of them, get them out there and do that. But they need to be connected into the healthcare team, right? Just like an aide is on the floor. And so we're doing, I mean, everybody's starting to do that, and it's like super cool. So we're going to do that. By the way, one of the things we're learning is, so we have like thousands of people that we're giving devices to. Training a disparate workforce is like, oh, I didn't realize like training is important, right? So it's like huge. You can't go forward unless they point the gun in the right direction, right? So training is another one, but technology is something but we're going to be out in the communities and not in hospitals using Pampers.
We have a question over here.
Marcia Reisig, Sutter Care at Home. So Bill, I agree. This is a very home care centric discussion. And I think it's got to be bigger than home care. I'd hate to call it post-acute or pre-acute, but it's something that home care is a piece of, but it's a certain population of patients that we're managing. That's my opinion. The big question I have for Bill number one, you guys did like the blockbuster deal of the year, Health South and Gentiva, and it was followed by Encompass and Health South. You guys are setting is that the trend? Are you guys going to take over the world?
Let me figure out how to answer that.
Is Sutter for sale?
Well, it could be.
So I do think that, so with the expected closing of the Gentiva transaction today, Groundhog Day, you know, I do think that it just kind of further illustrates you know, really the national desire to have home-centered care be the center of all care. And so I think, you know, for the specific population that is the most vulnerable, the most in need, and the most costly, I think that home-centered care really can be the solution. And I think, you know, it's not just skilled home care. I think, as you said, I think it's a critical, important part, but I think, partnering with acute care systems, with palliative care, with hospice, with longitudinal care providers, with bricks and mortar, I think, I really do think that it can be the biggest part of the solution going forward.
Okay, we have one more question here in the back.
Hi, Monique Reese with Unity Point Health. A couple questions. We're going back and forth between what I would call a traditional certified home health company and what I would call a population health type company and or partner. So is the real question is how are we going to transform our business model and our clinical care models to succeed in the future?
Absolutely. Just quickly, I've heard a lot about home care, and we talk about Medicare, and we talk about homebound, and we talk about readmissions. What about the patients who aren't Medicare and the patients who aren't homebound that get discharged? Who's caring for those patients to prevent readmissions? Where's the home care application for that? That's a wonderful business opportunity. We had probably at least 30 or 40 hospitals that were begging for that services and are willing to pay for it. So you could come out and under your benefit, you could provide non-skilled or skilled to patients that don't qualify, and who's willing to pay for it? Well, as for Medicare, who's willing to pay for it? Well, I can tell you who's willing to pay for it. The hospitals are willing to pay for it. The payers are willing to pay for it. And there are some services that you can provide to a non-homebound patient, like sending a nurse practitioner, advanced level practitioner into the home, and it's fully billable. So you can combine that non-billable component with a billable component and come out with a wonderful outcome.
Bill, one of the comments you made was in regards to use of waiver in ACOs and so forth. So we're part of Pioneer ACO, MSSP, commercial. We're in value-based contracts. So one of the ways we use and leverage that resource is partnering from a waiver standpoint to provide those services when it's not traditional certified home care.
What I would tell you from a nursing perspective is I see a significant gap in practice, competency, and acumen for care coordination. And I think for those of us who are nursing leaders, it is incumbent upon us to collaborate and work with our colleagues in the academic world to get this competency about care coordination. It is a very distinctive competency that is not within the curriculum for undergraduate right now. In Colorado, we're really working hard and pounding on our undergraduate programs about that, because without it, it is basically dependent upon us to do that training. And it is pretty significant. How do you approach a defined population? So you have an analytics program, great. How do you sort and look at what's important? And then how do you come up tactically with what is appropriate from a cost perspective and quality perspective for the high risk, the medium risk, and the low risk patient population based on where the highest cost and issues are in that population. So, to your point, in that transformation, I think it's really important from a nursing perspective that we in home care have the opportunity to own care coordination. There are a lot of people who are out right now thinking and saying, hey, I can do care coordination. I do think that we philosophically have that in our toolkit, but it needs to be honed. And certainly part of an interdisciplinary team, to Bill's point, all roads go to primary care. And that is a patient's home, a medical home. And contrary to what Bill number 3 says, I don't think that we own it in home care. I think that we have to partner very significantly and primarily with the PCP to really exact the outcomes that are best.
Okay.
Just to add on to what Aaron is saying, and some of the comments from the audience is, we also recognize that not everything takes a clinical licensed professional, right? So really making sure the mix of your team supports that. So one of the keys in value-based care is that you get to have that team and figure out how to deliver and who's the most appropriate to work to the top of their license, and who can actually do some things that are not skilled services. And so really looking at the analytics and looking at who's the driver. The skilled person may be the driver in the care coordination, but they also have a team, and how they partner, and do you, in taking advantage of care coordination, do you become the resource that is in the doctor's office to help actually facilitate care coordination?
So one more question over here, and then I want to move to one quick topic, so go ahead.
Thank you. Good morning. Randy Platt with Silverado, and I first wanted to thank all of you for speaking with us and being so candid. It's been very enlightening. 10 to 1 today, we've heard home care, and we've not heard as much about hospice. And obviously with home care and the evolution of its reimbursement, and hospice certainly following, I'd really like your view on where hospice sits in the future of home care, especially when it comes to the issue of patient choice, because one thing that's unequivocal is that we all are going to die, and we don't talk about death very openly. And I think in this system today, we see a real disparity between home care, home health, making that transition from curative care to palliative care into hospice. And we are a multi-service integrated healthcare delivery system at Silverado. And we're faced with this challenge every day. But talking about death and being prepared for death, and that incorporates hospice, at least today it does. What do you see as providers, the future being, both from a quality of life perspective, but also from the standpoint of reimbursement?
If I could just start that and maybe set the stage for the others. I think hospice really is at a crossroads right now from a government perspective more than anything else, and that's the issue that MedPAC's created. Should hospice be part of Medicare Advantage? You know, should it be part of an integrated payment model and integrated delivery model at that point? And the jury's out as to whether or not Congress would support that. MedPAC definitely leans in that direction. Some managed care plans want it because of the huge money that they might get out of the whole deal. Some say, I don't want to touch it at all. I think that decision is going to really set the stage for where hospice sits in the future. I think there's a growing body of people who would like to keep hospice separate and distinct. And I'm not even going to offer my own personal opinion on that. I mean, hospice is just an incredible service, but I think the industry has to step up and figure out where it fits in this. Is it a piece of a bigger thing, or is it its own in that way? And if it's going to be a piece of something, how's it going to fit into that mix? I mean, you talked about a spectrum of home health to palliative to hospice. That's not necessarily the path that everybody should take. It may be that home health and palliative is never in the mix. But we need in particular to guide the government on this one here, because if we let them guide it, if we let the MedPAC people guide it, we know we're going to go in the wrong direction.
All of my comments assumed that hospice was as much a part of home-based care as any other type of home-based care. It's just a part of it. And by the way, we didn't talk about meals or adult day or transportation or these case management, all of these things, that respite care, that help us do what is just going to happen, and that is we're going to provide more and more care more seamlessly in the community than we ever have before, every day more and more. And the only thing I would caution Bill on is to start talking about further segmentation. We need to stop. And one of the reasons we have this much discussion is because we've built, I think, a very good system, but we built it with all kinds of border regulations that stop us from being seamless, which are not, they don't match up with common sense, and so they will ultimately, gravitational influence will make them go away. And I talk about preparing ourselves for that which will ultimately be, and hospice is just a part of home care.
So one quick question before we move to closing. And this is changing the topic slightly, but I think we've been talking a lot about the growth and risk-based and value orientation. It's kind of an exciting time for home care broadly, I think. It does probably lead to more home care. And I was speaking with a large health system-based home care CEO recently, and just talking about how that's exciting, kind of the additional volume that will come, and perhaps they're well positioned for it. And what they said to me was, they said, well, yeah, that might be the case, but in the trenches, it doesn't feel so good. And we have more reimbursement pressure. And so, yes, strategically, maybe that's how it's going. But right now, it isn't how it feels. And obviously, a lot of traditional home care reimbursement is Medicare related. And so I guess my high level question is more regulatory in nature, which is, why does MedPAC hate home care? I mean, Bill, you're a pretty good-looking guy. Yes. Why do they hate it so much?
Marcia's right. It's and hospice
and
now,
hospice,
too.
yes, broadly.
The reality is MedPAC hates any sector that's successful. And I think part of it comes from the nature of some of the people who gravitate towards MedPAC itself. They would never let most of these people in this room onto MedPAC as a commissioner. It's certainly not me. Marcia might be having a better chance, and you, Adam, even a better chance in that regard. But if we want to be unfair to them, MedPAC just simply is all about cutting reimbursement. That's their only mission. And they come from the Office of Management and Budget, and that, this standard operating procedure is cut, cut, cut. If you want to be fair to them, look, let's take a look at home health, for example, MedPAC-wise, from their perspective. Rates have been cut 14 times in the last 16 years, yet the industry has grown each and every year. The industry's maintained its Medicare margin each and every year, sometimes growing margins in the face of payment cuts. So they're sitting there saying, we have to be overpaying. Again, that's your success. That's why they're picking on you in that way. I don't like the way they're doing it. I don't think any of us like the way MedPAC is analyzing things, but they have no idea where the bottom is on the price. So they keep pushing the price down until something breaks. They don't care about the consequences of it breaking, but they keep pushing the price down, and they push the price down so far in home health, and we have 300 new home health agencies come in. We have Kindred acquire Gentiva. And in the face of what looks to be an economic disaster for all of home health, we see margins going up and new entrants wanting to come to business. On the hospice side of it, the exact same thing. I mean, in the last 10 years, all hospice growth has been around for-profit hospices. And there's nothing wrong with somebody based on their tax status. But the impression that's left with is that there's money to be made in hospice. And so MedPAC hates it because it's successful. I think the reason why home care and hospice is successful is because it's the right service at the right place at the right time. It is a solution, and we threaten institutional interests otherwise, be they hospitals or doctors or anybody else who's not doing home and community-based services. So I wouldn't want to be a MedPAC person, because you have to grow up, wake up every morning thinking, I need to be mean.
So Bill's got a lot right there, and the problem is they don't have the ability to look at the best uses of resources. They can't say, I'd rather take money here and put it here. They look at cumulative spending in a segment.
They're totally in silos.
But here's the bottom line. Here's the bottom line. We as an industry need to collectively get together and prepare and produce a value proposition that would redefine the benefits. Because let me tell you something, CMS is open to hearing a redefining of the benefits that would add more value. And it's really simple. It's about having standard technology. It's about standard care transitions. It's about standard medication reconciliation. It's about standard care coordination and care management. It's about following a patient beyond the 60 days that we care for them. If we did that, I can promise you a value proposition would be easy, and they would be pumping money into this industry. But we're too busy clawing one another's eyes out to be able to get there, and we got to move beyond this.
So we have 2 minutes left. It's saying the end. Do I have 2 minutes for people to offer 10 seconds of advice? Okay, let's go. So let's go around the room. Not go around the room. Let's go up on the panel. That would take a while. And maybe 10-second closing advice, kind of a soundbite.
Yeah, I think broadly, I appreciate a lot of the comments that were made. I think there always will be a role for a home care hospice provider who provides good outcomes, good care coordination, good communication, irrespective of size. I think that integration and partnership with longitudinal care providers is going to be another really important thing going forward. It's 10 seconds.
And I would say hone outcomes, expertise, and satisfaction, and create a business model and go out and partner. I absolutely think there's a role for everyone, but it requires thinking it differently.
I suggest bifurcate your focus, meaning you have to still attend to the today. You've got a lot of oversight there, you've got a lot of compliance, you've got a lot of demands on you, but also commit resources towards tomorrow because you have this incredible opportunity out there and you don't want to be left behind.
So accept the change is coming organizationally. Be really good at the thing that you do. Expand within a market because bigger is better. Work on efficiency because nobody's going to pay you more. And focus on effectiveness, which is to drive an outcome.
And so my advice would actually be to partner and to lead, to figure out ways to lead past the current bundles, past the current ACO reimbursement models, and figure out how you can own that and lead that in becoming partners with health systems.
Kick up your clinical services a notch or two, and physician engagement is imperative to being successful in anything that you do, because it's one of the challenges that the industry has, and the threats is lack of it.
Thank you. Thanks, guys. I'd ask you all to give a round of applause to our panelists. Thank you very much. We appreciate it. Thanks for being so frank with everybody.